Hey everybody, thanks for coming to my case study on brain meningitis using the MRI modality. Okay, so the patient history is it's a 64-year-old female. She had multiple lesions on her body. Her son actually came from overseas with the same lesions, and she just got them from her son. She then went overseas where she developed a decreased GCS. She became febrile and became drowsy on the way back on the plane. So on her lumbar puncture, she had a cloudy CSF, which is indicative of meningitis. The gold standard for diagnosis is a lumbar puncture, which indicates the potential for aseptic or bacterial meningitis. She also had increased intracranial pressure, which is associated with bacterial meningitis, and the sensitivity for lumbar puncture for meningitis is 70 to 85%. The sensitivity decreases by 20% following antibiotic post-treatment antibiotics. Okay, so following numerous scans of MRI and CT, she did get diagnosed with strep A meningitis. She had several days of seizures and a GCS score of 3, which is the lowest score you could get, which means she has no eye opening, no verbal response, and no motor response. So streptococcal meningitis is an acute inflammation of the membrane covering the spinal cord and brain. The mortality rates are between 5 to 40%, with most survivors, 25 to 50%, develop neurological deficits. Meningitis occurs when a bacteria, in this case is group A Streptococcus, enters the nasopharynx and enters the bloodstream through mucosal invasion. It then crosses the blood-brain barrier at the subarachnoid space, causing acute inflammation, and the usual treatment is with antibiotics, and with early intervention you get a better outcome. Okay, so the first step of an MRI is gaining consent. So you have to explain the risks, benefits, and alternatives to the patient so they can make an informed decision and give the informed consent. Ensuring that informed consent is covered is an ethical and legal obligation to ensure patient autonomy is not compromised. However, in this case, the patient is intubated and she's not responsive, so she can't give her consent. If this is the case, a designated surrogate decision maker will be elected, usually by the family. To be able to qualify on behalf of the patient, they have to show understanding of the patient's values and wishes and an adequate understanding of their clinical history. So this is the MRI screening safety checklist that's given to basically all patients that enter the MRI machine. So they fill out the name, everything, and majority of this you would have to cover, so cardiac pacemakers, aneurysm clips, any sort of electronics or implants that are inside the body, previous surgeries, any injuries to the eye involving metallic or metallic fragments, pregnancy, if they had the scan before, and getting this signed off by the patient or the delegate and the doctor or staff. So this is the gadolinium contrast administration sheets. So basically, they would have to go through this again with the staff or doctor or nurse, in this case because she's not responsive. And you'd also consult with the family for previous history. So this asks for any contrast injection reactions, previous contrast exams, any allergies, if they ever had asthma, any kidney problems, medical conditions, they're currently breastfeeding, and the prior information sheet. So then again, they would sign off and staff would sign off on here. It's important to note that eGFR has to be over 30, or else you would have kidney problems. So following on from screening, it's important to run through a check on the patient, as diamagnetic and paramagnetic objects have the potential to migrate within the body or heat up due to RF pulses. These diamagnetic and paramagnetic objects also have the potential to create artifacts on the scans. Clothing can also pose an artifact risk if they produce static, causing a spike noise artifact. Usually some implants are conditional and can be used only in the 1.5T scanner rather than the 3T. So when transporting the patient, there's obviously some risks, especially from the ICU, which she was from. There are adverse events that can occur. Usually the events occur with the physical nature of transporting patients, changes in environment or relocating monitoring equipment. And about 14.5% of patients being transported from the ICU have had a major critical event such as desaturation and endotracheal tube obstruction. To mitigate these risks, relevant equipment and staff should be accounted for prior to the transport. So these are some MRI safety considerations, SAR, or specific absorption rate, which is when the tissue within the body can heat up during the MRI scan. Usually the MRI scanner will not allow the operator to exceed a certain SAR. However, in patients that have reduced thermoregulatory capacity due to factors such as cardiac impairments, fevers, or drugs that affect thermoregulatory abilities, more care should be taken. The issue can be alleviated by increasing the scan time, by increasing the TR or time to repeat, reducing the number of slices in the acquisition, and reducing echoes in multi-echo sequences. And the next one is zoning. MRI requires a strong static magnetic field to be permanently on. The strength of the field can accelerate ferromagnetic objects into the bore. Therefore, it is important to respect and maintain the zone lines. There are 4 zones which you can see on here. Zone 1 being outside the room, where it's unrestricted, for people just walk by. Zone 2 is where the patient is brought in to screen. Zone 3 is a console room, and Zone 4 is inside the MRI magnet room. Let's cut that. For this patient brought down from the ICU, she would need to be screened and moved into an MRI compliant bed in Zone 2, as just covered. Moving over. A protocol on how to handle emergency in Zone 4 is also required. So when she gets moved over, ideally you would give her a body check for potential ECG leads or electrodes that can heat up in the scanner and potentially burn them. Tattoos can also be inspected as certain pigments contain metallic elements and can cause an artifact if it is over the region of interest. The clothing ideally should be a patient gown, as previously stated, it can cause static artifacts. Breathing and monitoring equipment should be swapped over, and vital signs should be monitored in case of emergency. Okay, for the procedure, from the MRI bed, the patient should be transferred onto the table. The head should be in the center of the coil, elevated with a sponge to make sure it's in the center and that the chin is up. The head should also be aligned to lasers vertically, with the vertical line running through the nose and the horizontal line on the glabella. To increase patient comfort for more alert patients, a sponge can be placed under the knees to alleviate back strain during the long scan. Earplugs or headphones can be used as the 1.5T can hit 130 decibels, which is behind that. So that's a sponge just under there, just for longer scans. And an alarm bell should also be provided. So using brain coils for MRI, a 20-channel coil can be used over 64-channel coil, 64-channel, as it does not cover the patient's face as much. So you can see here, it really surrounds the face, and for more claustrophobic patients, it's not ideal. However, the 64-channel coil does provide better anatomical measurements compared to the 20-channel, which is this one over here. 20-channel coil also has a mirror which allows the patient to watch a movie, which in combination with effective communication does reduce patient claustrophobia and anxiety. Patient comfort is important as MRI sequences for longer acquisition times are more prone to movement artifacts, which is just on there.
Sorry, Leon.
Yes.
There's an issue with this that I quickly need to fix, and I really apologize. so
Okay.
sorry.
Oh, sorry. Alright, so for the MRI sequences, we use T1 and T1 postgate. When looking at MRI of the brain for bacterial meningitis, the key clinical features are hydrocephalus, abscess, cerebritis, thrombosis, infarct, ventriculitis, and extra-axial collection. TI-weighted MRI or spin lattice relaxation uses the recovery of magnetization along the longitudinal axis following inversion recovery. T1 has an 82.8% sensitivity to meningitis. T1 enhances the fatty tissue and suppresses water. As the two biological determinants of T1 relaxation is the presence of edema and an increase of interstitial space. T1 is particularly useful in this case as patients with meningitis have interstitial cerebral edema. This would show as hyperintense. A key feature seen as hyperintense on T1 is cerebritis. Cerebritis is a brain abscess caused by infection. These lesions are often seen as ill-defined lesions in the early stages and develop a necrotic center with a fibrous and dense border as they progress. On T1, with contrast, the rim is often hyperintense relative to the adjacent white matter. Post-GAD T1 is also used to visualize any lesions that uptake any contrast. So this is a T1 from the patients, and this is the previous of the patient as well. This is actually just a catheter they placed in. It's all changes in the ventricles, and this little lesion just over here just differs from the previous one. So MRI sequence T2 weighted imaging is dephasing protons in the transverse plane. T2 enhances the water and suppresses fatty tissue. For abscesses, T2 imaging provides a hyperintense rim. Often patients with bacterial meningitis can develop white matter lesions. White matter lesions are best seen on T2 and FLAIR as they show up as hyperintense lesions. CSF and ventricles can be assessed as they also enhance on this weighting. This is important as complications of meningitis and obstructive hydrocephalus, multiloculated hydrocephalus, and ventriculitis. So you can see the CSF is hyperintense over here, relative to the matter over here. And once again, that's just catheter. And you can see that the lesion does show a bit more on the T2 over the T1. MRI sequence FLAIR. As previously stated, T2 FLAIR is an important sequence in visualizing the enhancement of the lesion. T2 FLAIR is similar to T2, however it has an extended TI and TE timing. FLAIR also enhances lesions located adjacent to the ventricular margin by suppressing signal from the CSF. These locations are usually periventricular, juxtacortical/cortical, and infratentorial. When looking at MRI with meningitis, a key non-specific imaging feature is leptomeningeal enhancements. The two ideal sequences that best appreciate leptomeningeal enhancement are post-con FLAIR with a sensitivity of 100%, or post-con T1 weighted with fat saturation has a sensitivity of 76.2% for pyogenic meningitis, which is what strep A falls under. The reason for the high post-con on FLAIR sensitivity is the differentiation between vascular and meningeal enhancements. So this is actually not from the patient, this is just a FLAIR of a different one. So the CSF is suppressed over here, and you can look at the adjacent tissues for any brightness. Diffusion weighted imaging highlights the restricted diffusion of water through the brain. Its typical clinical applications for brain scanning include acute brain ischemia, tumors, and white matter diseases. Patients with strep A usually have accompanying intraventricular diffusion restrictions that are highlighted on diffusion. Diffusion has a 79.6% sensitivity to changes in signal in the intraventricular region, intraparenchymal region, and sulcal regions. Diffusion also provides insight into viability of brain tissue after ischemic strokes, which is usually secondary to acute meningitis. This occurs in 10 to 20% of patients. So this is actually from the patient, anatomy. You can see that the coral plexus, everything up there. Little lesions, usually from the catheter that passes through there. And look at the previous as well. There are some minor changes just up here. So susceptibility weighted imaging, or SWI, uses the magnetic susceptibility in each tissue type as a blood ion, such as blood ion in calcifications. One of the major benefits of using SWI is its relatively high sensitivity to strokes at 66.7%. SWE, when used in conjunction with diffusion, allows for an accurate diagnosis of ischemic stroke. Another benefit of running a SWE sequence is its ability to delineate pyogenic or bacterial abscesses from other intracranial cystic mass lesions. One of the ways that bacterial abscesses are defined is by the dual rim sign, where the outer ring is hyperintense and the inner ring is hyperintense, all relative to the center of the abscess. So we look here, there is some changes up here, either occipital horn or the lateral ventricle. There is some changes up here as well. So ADC maps are derived from diffusion. It also has the ability to detect the diffusion of water that are affected by brain lesions. ADC complements diffusion. Unrestricted diffusion of water is seen as a high intensity on diffusion, however, is a low intensity on the ADC map. In instances of patients with an abscess, there's often low intensity due to the restricted movement of water with an abscess. Sometimes a diffusion can produce a T-time shine effect, where lesions may be enhanced due to long T2 relaxation time of fluids and giving a false enhancement of diffusion. Therefore, an ADC is required to confirm lesions and abscesses that are seen on diffusion. This is the diffusion scan, so there is restricted movement of water in here. Yep, see tumors or lesions up there, and catheter once again, just up there. So time of flight sequence. Within time of flight is a way to visualize the arterial and venous vessels within the brain without contrast administration. It can be used to reliably diagnose peripheral vascular disease and cervical carotid disease. For patients with meningitis, around 43.3% have some sort of arterial abnormality. Patients with within the acute phase of meningitis often develop vasculitis, which is the inflammation of the vessel. It's characterized by the narrowing of the vascular lumen. So what are potential modalities of MRI? First one, we have CT. The main advantage of CT over MRI is its speed in scan acquisition times and access. Its main use in meningitis imaging is look for increased intracranial pressure, which is a contraindication of a lumbar puncture. In this case, MRI has superior sensitivity in monitoring and detecting meningitis and its associated complications. Its high diagnostic efficiency makes it ideal modality for meningitis. So ultrasound can also be used, however, it's only for neonates and infants. It can assess the meningeal layer, ventricles, and parenchyma, and has 85% sensitivity to acute bacterial meningitis. This is the request form, your statement, and all the references.